Good evening, doctors. This is Harish Murthy from Microlabs. A very hearty welcome for today's webinar. The topic for today's webinar is hypertension and stroke, reducing the vascular risk. We have an eminent speaker, a neurologist for that matter, to speak on a very apt subject for his specialty. Before that, I would just like to tell you that Microlabs as such, we have been into a lot of such scientific activities and initiatives, and I'm very happy and proud to share with you that this is the 50th year of Microlabs in this country. So with all your support over all these years, we are now celebrating 50 years of our existence in India. And not only in India, we have also been, in 30 to 40 countries elsewhere also where our products are available. So thank you for all the support which has made us, become a very strong pharmaceutical organization in this country over the last 50 years. Coming back, I would like to introduce the chairperson for today's webinar, Dr. V. Murugesan. Dr. Murugesan is a consultant cardiologist, did his MBBS and MD from Tanjavur Medical College, and then went on to do his DM in cardiology from the Madras Medical College in 95 to 97. Dr. Murugesan worked in the cardiology department at Tanjavur Medical College. He has been a member of the CSI, ACC, as well as ESC. He has a long 25 years of practice in the field of cardiology and has participated in and chaired several national conferences. Also has been a DNB cardiology examiner. Currently, Dr. Murugesan is associated with Rohini Hospitals, Tanjavur. Welcome, doctor. It's a privilege to have you as a chairperson for today's webinar. I would now request you to take over and then introduce the speaker and start the proceedings.
Can you screen the other slides?
Yes, it is there. Yeah.
Good evening to all of you. A warm welcome. I take this opportunity to thank the Microlabs for asking me to chair today's webinar. For today's webinar, we have an eminent speaker, neurologist from Apollo Hospital, Madurai, Dr. S. Meenakshi Sundaram. He is a gold medal winner and best outgoing student for the year 2000 from the National Institute of Mental Health and Neurosciences, Bangalore. He has been awarded the best research paper in the 10th annual conference of the Indian Academy of Neurology, which was held in Lucknow in 2002. He is one of the editors of the South Asian edition of the book Practical Neurology by Jose Biller. He has more than 30 publications in reputed journals, and he has been co-author in more than 15 books. So today he will be talking on the hypertension and stroke and how to reduce the vascular risk. We all know that stroke is the leading cause of death and disability all over the world. And hypertension is one of the major vascular risk factors for stroke. Fortunately, if we adequately control hypertension, we can prevent the substantial proportion of the population from having stroke. But whenever we want to treat hypertension in patients with acute stroke, we should be very cautious. The hypertension level should be adequate to have the necessary cerebral perfusion. But at the same time, we should not aggravate the intracranial bleeding, and we should not exacerbate the cerebral edema. So today, Dr. Meenakshi Sundaram will be discussing about the non-pharmacological as well as pharmacological strategies for the treatment of hypertension in stroke, as well as what the guidelines suggest, what is the BP goal in various strokes, whether it is ischemic or ICH or in subarachnoid hemorrhage. So over to you, Dr. Meenakshi Sundaram.
Thank you very much for the very kind introduction, sir. I would like to place on record an important point that my topic is going to be focusing only on hypertension management vis-a-vis acute stroke, acute ischemic stroke. I'm going to touch a bit upon the preventive aspects, but not much, because my area of interest is mainly acute stroke. I do not do any primary care. It's mainly stroke and beyond stroke. That is the only thing. And I am not planning to give guidelines to people. I'm just going to share my experience. With that, can I share the slides, sir?
Yeah, you can share your slide.
I can share my slides. Are my slides visible?
Yeah.
Yes, sir.
Yeah. Okay. Thank you, sir. Thank you. So at the outset, my sincere thanks to my colleagues, Dr. Karthik, Dr. Suresh, my wonderful colleagues at my hospital. Dr. Murugesan, sir, thank you very much for chairing this session. Friends from Microlabs, thank you very much for inviting me for this talk. The learned audience and the goddess Meenakshi, the Supremo of Madurai. So I also would like to thank all my teachers from whom we are all part of and who have always been guiding us in all our endeavors. So I opened this talk with the million-dollar question. What do you do with hypertension in stroke? Now, would you decrease the pressure? Would you increase the pressure? Would you leave the BP as such? You can do all the above, you should do none of the above. So these are 5 choices which I have given you. In order to generate some degree of interest in discussion, I request the audience to post answers with the question and the choices. For instance, you could just post the answer, question 1, choice A or choice B, whatever you do. I request Mr. Harish Muthu to kindly inform as to which platform they should post their answers. And he has been kind enough to inform us that after some 10 odd questions I'm going to post here, he has planned to give some small pen as a token memento to the winner who gets the maximum answers correct. So Mr. Harish, could you kindly tell the audience as to where they need to post their answers so they could do that as they are listening to the talk, and we
Yes.
can collate that data and just provide them as a token. That would increase the interaction amongst us. So could you tell
Sure,
us
sir.
that, sir?
Yeah, I am posting my email ID on the chat screen for the audience to see, and they can post it on my email ID and we will collate it.
Yeah.
Thank you, sir.
Can I see the chat, sir? Have you put it on the chat? Are they accessing the chat? Are they able to access the chat, sir?
Yes, it will be done, sir. They will be seeing the chat. For us, can you please do that?
Dr. Meenakshi Sundaram, would you like to
Hello, sir.
specify
Like
the
you have
acute
to
stroke, whether it is
you have to
ischemic
spell the
or
email ID.
hemorrhagic?
Sir, I'm going to come back to that, sir. That will be the entire discussion, all the things about, sir. I'm going to come back to you, sir.
Look, for this
That would be
question to be
understood, sir.
answered, for this question to be answered,
Sure, sir. For this question to be answered, you are asking which stroke this is.
yeah.
Again, I would leave that question open at this point of time, and I would like to answer that question during my talk, sir. At this point of time, which stroke it is remains open here. So have you posted the email ID, sir? Mr. Harish, have you posted it?
Yes, sir, it is done. You may continue. In a moment, it will be there. They can take it and send their answers.
Fine. So would they be putting the answer? Is it possible for them to post into the chat box itself separately?
Yeah, the moment they post it, it will be collated, sir. In the chat box, it will not be coming. They will have to mail it to me at harishmurthy@microlabs.in.
Sure. So
Yeah,
they
we
could,
will do that.
because the answers, every time it comes, the answer would come also. So they have to post it each and one single mail to you. Okay, right. Here we start now. Let me go to the answer. How do we, yeah. So stroke and hypertension happens to be one of the most controversial topics in neurology, because tons of research has been done. And
Take it
even
down, na,
today, we
Harish
don't have
Murthy,
completely clear
Nicolabs.in.
answers.
आप post करो ना रे उसमें वहाँ पे. How can it be possible here?
All right, doesn't matter. So if it is not possible, leave it. They can write the answers in a paper and they can see. It's okay. Sir. No issues about it.
No,
So
I would request the audience to just note down my email ID. I am spelling it. It is Harish Murthy, Harish Murthy, Harish Murthy @microlabs.in, MICROLABS.in. Harish Murthy @microlabs.in. Kindly note down and you can send your answers on this email ID.
I'll wait for a minute for them to digest that information. So coming back to this is one of the most controversial topics in neurology with tons of research, but without clear answers. Because there are no dogmatic guidelines, and I'm not sure whether the last word in this topic would ever be written. And the reason why we say this is exactly what Dr. Murugesan has just pointed out. Stroke is a heterogeneous disease. On one hand, we have ischemic stroke. On the other hand, we have hemorrhagic stroke. Even amongst the ischemic stroke, we have subtypes of ischemia. You can have a cardioembolic stroke. You can have an atherothrombotic stroke. You can have a lacunar stroke. And when you come to hemorrhagic stroke, again, you would have parenchymal intracerebral hemorrhage called a spontaneous ICH, which should be treated differently from a subarachnoid hemorrhage and so on and so forth. Now, let me take you through this case minute. This was a 54-year-old lady who was transferred from another hospital for management of stroke. She presented 6 hours after stroke. She had mild right hemiparesis when she walked into the other hospital. A CT scan of the brain was done at this time. It was reportedly normal. Usually, within the first few hours of acute ischemic stroke, CT scan hardly ever shows any gross abnormalities, which was the case in this patient as well. Now, there was no documented past history of hypertension. At this hospital, blood pressure was recorded to be 190/120. She was given 20 mg of nifedipine and another tablet, name not known, before transfer, and now this patient got transferred to our hospital. So by the time she reached our hospital, it was 2 hours subsequently, that is 8 hours post-stroke, blood pressure 140/90, and now she had dense hemiplegia and aphasia. Now here is my question. Why did this patient deteriorate? There are 4 choices. Either it could have been an iatrogenic deterioration because the blood pressure was reduced. Was it just a natural history of the disease, which you would expect? Stroke is, after all, a progressive disease, at least in the first few hours. Or this patient suffered ischemia separately again. There was a recurrent ischemia. Or would you consider the choice D, wherein you'd say all the 3 mentioned choices could explain her deterioration? So you could post choice A, B, C, or D for question 2 to Mr. Harish Muthu in his email, harishmuthu@microlabs.com. Now, let me take you to the answer. You can just put question 2 and choice. That's it, more than enough. And press the push button, and then I will go to the answers. Now, the question we need to address is that, did she deteriorate because there was a natural history of the disease that stroke could have progressed, or was it iatrogenic? Now, when you look at that, you have 2 intervals separately in this patient. The first time she presented to another hospital was a 6-hour window. At this point of time, her power was almost grade 4/5 because her weakness was just right hemiparesis, which I mentioned. Now, we treat her, if it was due to a natural history of the disease, the progression would have happened early than late. The maximum nadir, at least the worsening should have been at 6 hours than the 2-hour window. Here is a patient who at 6 hours post-stroke was having only mild hemiparesis, but after another 2 hours, she suddenly deteriorates, which means it is not just natural history. Probably it is iatrogenic in nature, which is the most likely reason why this patient deteriorates. So this answer is, it's an iatrogenic reduction, which iatrogenic cause due to aggressive BP reduction, which is a cause of deterioration. So to understand what happened in this case, we need to look at a few parameters which are important for stroke physicians. We need to understand these data as to what is cerebral perfusion pressure, what is mean arterial pressure, and what is intracranial pressure, and what are the relations. So now I have given 4 equations for all you to assimilate. So you have to tell me which are the 4 choices A, B, C, D is correctly mentioned here with regard to the 3 parameters which I have just mentioned: cerebral perfusion pressure, mean arterial pressure, and intracranial pressure. So I give you about 10 seconds for you to put in the answer. Send it to Mr. Harish Muthu by email. You can just click on it, and then I will go to the next slide. I assume they would have sent the answer. Now I'm going to discuss this question alone. Now we know what is mean arterial pressure. It is diastolic pressure plus 1/3 of pulse pressure. So this is the pressure which actually is responsible for tissue perfusion to all organs, including the brain. This mean arterial pressure has to work against the tissue pressure, which in this case is the intracranial pressure. So the difference between the mean arterial pressure and the intracranial pressure would what reflect the cerebral perfusion pressure. Therefore, cerebral perfusion pressure is mean arterial pressure minus intracranial pressure, choice B. Now, having understood this very important concept as to what is mean arterial pressure, intracranial pressure, and cerebral perfusion pressure, we need to look at the second important aspect to understand what is cerebral autoregulation. So, which are the following statements about normal cerebral autoregulation with respect to cerebral perfusion pressure, cerebral vascular resistance, and cerebral blood flow is correct? Now, I've given you again 4 choices. If you read this, you could take a minute to assimilate this, around 30 seconds, and you could post the answer again into the email provider. Take your time to look at this data. While people are actually putting their answers there, Mr. Harish, was it possible for audience to post their answers there? Was it possible? Did you receive answers?
I have not yet received, but we have put my my email ID is visible to them on the chat box.
Because it might be difficult for people to post on the email. Usually we have a chat box for everyone, and there is an individual chat box, and there is a, what shall I say, a chat box which is visible to everyone. So usually in my presentation, I ask them to put in the individual chat box, but you told me that the other audience are not joining.
Exactly. Yes, there are 2 different links. Yes.
Doesn't matter. So whatever it is, they can post it. Let us see this. No issues about it.
Sure.
So I'll wait for about another 10 seconds if people could post that, and then I'll discuss this, because this is again important for people to understand as to what is happening in the case unit which I just presented. I'll go to the answer. Now I told you what is cerebral perfusion pressure. It is a difference between the mean arterial pressure and the intracranial pressure. At any particular point of time, the ICP is a constant which could be elevated or it is normal, but at any particular point of time, you have an ICP. The MAP is constantly changing. If the MAP increases, the CPP will also increase, we all know, because the perfusion will increase. In other words, mean arterial pressure and cerebral perfusion pressure are proportional. Now, the cerebral blood flow will be determined by 2 factors. One is there should be a pressure to perfuse the tissue. there is a tissue vascular resistance which will actually oppose this perfusion. If the cerebral perfusion pressure increases in any system, now the brain would get flooded. In order to prevent that, the cerebral vascular resistance will consequently increase by causing arteriolar constriction. For any increase in cerebral perfusion pressure, there will be arteriolar constriction so that the cerebral perfusion pressure is not directly transmitted to the tissue. Vice versa. If the cerebral perfusion pressure decreases, the cerebral vascular resistance will decrease because the arterioles will dilate. This is extremely important, and this concept is called as autoregulation, which is very important in the brain. This maintains the cerebral blood flow rather accurately. You require 50 ml per 100 grams per minute for blood to flow through in the brain. And over a very wide range of mean arterial pressure, which can be as low as 50 and which can be as high as 160, over this huge range, the cerebral blood flow will be accurately maintained, and that is cerebral autoregulation. If the mean arterial pressure increases beyond 160, as I mentioned to you, if the mean arterial pressure is increasing, more and more vasoconstriction is happening. But if the MAP is more than 160, all the cerebral vessels have now constricted. There is no more cerebral vessel to constrict. In other words, the vasoconstriction has got exhausted. At this point of time, the hydrostatic pressure increases. There is cerebral edema. Or the blood-brain barrier breaks. The patient has got hemorrhage. Therefore, there can be two consequences of this. You have a cerebral edema leading on to hypertensive encephalopathy or a posterior reversible encephalopathy syndrome on one hand, or the blood-brain barrier breaks and the patient has got a hemorrhage and you have a hypertensive hemorrhage. What happens if the MAP falls below 50? As I mentioned, as it keeps on falling, the vessels keep on dilating so that the cerebral perfusion is maintained. But below an MAP of 50, this cannot compensate any further and cerebral structures undergo ischemic changes. This autoregulation is very important. So what is this autoregulation? The answer to this question is that whenever the cerebral perfusion pressure increases, the cerebral vascular resistance must also increase so that the brain will not be flooded, so that the cerebral blood flow will decrease. This is in normal situations where autoregulation is completely functional. Whereas in stroke, the autoregulation is dysfunctional. Now the blood flow in the dilated vessels distal to the occlusion, now they are all dependent on the systemic BP only, because they are not actually auto-regulating, because there is an ischemic zone. So now any perfusion beyond an occlusion is dependent on the systemic BP, because of which if the BP falls, the cerebral blood flow will fall. If the MAP falls, the cerebral blood flow will fall. If the BP is increasing, the cerebral blood flow is increasing. Therefore, never allow the mean arterial pressure or the blood pressure to fall below any critical values, because if you do that, the cerebral blood flow will start falling and the patient will worsen, because the ischemic core of the infarct is actually increasing in size, which is exactly the reason why the patient had presented in case when it deteriorated. And therefore, the message is that in the setting of acute stroke, you should try to achieve euglycemia, normothermia, but never a normal blood pressure. This is called as permissive hypertension, because in this case, we did not know the previous blood pressure status of the patient. It was not known to us, in which case, actually, we have to be more cautious. If the patient is known to be hypertensive, and we know that this control was always poor, there are patients who are hardly complained with therapy. Even if they are complained, they miss medications constantly. When this happens, we need to be even more cautious in reducing the blood pressure. The reason is because of the very important curves which I have shown. take a minute to look at this curve. Let me explain this curve to you all so that you will understand what is going to be happening in a patient with stroke who has got hypertension vis-a-vis the patient whose blood pressure was normal. Any person in whom you did not know the previous BP has to be assumed to be hypertensive unless proved otherwise. So in this graph, if you see that, you can see the mean arterial pressure down there on the x-axis. You can see the cerebral blood flow on the y-axis. You will see that over a huge range of mean arterial pressure, the cerebral blood flow is just maintained. As the mean arterial pressure increases beyond a critical phase, which you can see here, beyond that point of time, let me see whether I can draw that and show you. Can I draw that here? I think I can annotate here. Yeah. You can say beyond this point of time, we can see this. Only at this point of time, when the BP goes beyond a particular time, is when the cerebral blood flow starts increasing. And same also here when you see that. Now, if you look at that in a hypertensive individual, this is shifted towards the right side. And therefore, even at a higher mean arterial pressure is when the cerebral blood flow will start falling. Therefore, it makes good sense to understand that let the blood pressure be little higher in this patient. If we don't do that, then you are going to risk ischemia in this patient. That's the reason why you never allow the blood pressure to fall critically in these patients. With that, let me take you to the next slide. How do I take it out, this annotation? Anybody can teach me this? Should I remove this annotation here? No.
Yes,
I
sir. You
think-
just click on that pen back, that annotation top left corner, sir, below, above the mic.
Yeah, tick corner.
Yes, sir.
And what do you
Top
do?
left corner, sir. Bottom of the above the mic, sir. You can say there is a one small pen.
I can see this. This is a mic. Annotate
Yeah,
it.
above. Yeah, there is a one pen option is there. Just you click on that, it will.
I don't know how to remove this. Doesn't matter. Let it stay here. Let me see this. Yeah. Okay. Clear my point. Right. Yeah. Got it. Not moving. Yeah. So remember, the hypertensive effect after stroke is transient. Within 7 to 10 days, the blood pressure starts falling by 20 to 10 millimeters. You must remember this always when you have thoughts of aggressively controlling blood pressure in stroke. Let me take you to the second case with that. This is a 60-year-old lady who was admitted with stroke. She has left hemiparesis. She had history of myocardial infarction 3 months ago. She had been on angiotensin converting inhibitor and beta blocker since then. ECG at admission did not reveal any fresh changes. Now, what would you do with the antihypertensives now during the admission? Would you stop them because the blood pressure, as I mentioned, is not very elevated? Would you continue as such? Would you increase the dose? Would you decrease the dose? So you can again post it in the email if it's possible. I'll wait for 10 seconds and then take you through the answer. Just put question 5, choice A, B, C, or D.
The
Now, let me
email is
give you-
visible on your chat box.
Sure. No issues. So in this patient, actually what happened in this patient was that's a real, all are real case scenarios. Antihypertensives were stopped on admission. On the next morning, she complained of chest pain. The review of chart showed the systolic blood pressure was 160 to 180 millimeters throughout the night. Repeat ECG and cardiac enzyme assay revealed non-ST elevation myocardial infarction. Now, you have to think differently in certain situations. Now, in a patient who has got a recent coronary artery disease, you should weigh the benefits of keeping the blood pressure high versus reducing it. Because when you discontinue the medications, it was inadvertently missed. It increases acutely the cardiac afloat and oxygen consumption, and therefore it can predispose to myocardial ischemia. Abrupt discontinuation of the beta blocker resulted in enhanced sympathetic activity and rebound hypertension, and therefore this is a huge risk for increase of cardiovascular events in patients with already having coronary artery disease. So in such a scenario, you better leave the patient as such on whatever medications they are on. There have been trials done as to looking at whether we must reduce the blood pressure, whether we must leave the blood pressure as such, whether we should continue the antihypertensives, whether we should stop them. In a patient who does not have such risk factors, the house is open. You could either leave the medication as such, or you can stop also. There is a trial called COSAC trial, which looked at whether we should continue the drug as such or we should leave it. It did not give us clear answers. So you could choose either option, but in special circumstances, like in the scenario of myocardial infarction recently, such scenarios you should be cautious. You should allow the medications to be continued as such. And that's a message in this case, winner 2. So we must ask this question, why does the blood pressure go up following stroke? The most important reason why it happens is because there is an ischemic zone, as I mentioned. You require a higher perfusion to perfuse the ischemic region. This is a compensation. Obviously, there will be other etiologies, like a white coat phenomenon, or a patient had pre-existing hypertension, but it was not detected. It could be a sympathetic stimulation, stress. People have fear of paralysis, hospitalization. You're going to put in central lines in them, pain. Activation of neuroendocrine systems is well known in patients with stroke. Or it may be because of Cushing's reflex due to raised ICP. Or in some patients, there would be ischemic damage to the brainstem or hypothalamus causing this. Now we should ask this question, why should we in fact lower the blood pressure in acute ischemic stroke? It makes sense because we all know hypertension is the most important risk factor for stroke. We tend to achieve normoglycemia, normothermia. Why not achieve normal blood pressure also? After all, if you reduce the BP, the cerebral edema will go down, hemorrhagic transformation of ischemia will go down, and in the patient who got a hemorrhagic stroke, by allowing the BP to be high, there will be more hemorrhage, the volume of hemorrhage would increase. And in this case, winner 2, I showed you, higher the BP, more will be the cardiac workload. So you reduce the blood pressure. And we all know it is not just the heart or the brain alone. We have other target organs like the kidney, which can suffer target organ damage. On the other hand, if these are the arguments as to why you must lower the BP, there are also problems in lowering BP. I mentioned that in a setting of loss of autoregulation, there will be perfusion failure. Therefore, today, the treatment is to have permissive hypertension in order to preserve the penumbral perfusion, which can result in potential salvage of the ischemic neurons. So this is a data from International Stroke Trial. Look carefully at this data. Now it says that for every 10 millimeter rise of blood pressure beyond 180, the mortality increases by around 4%. On the other hand, for every 10 millimeters fall of blood pressure below 150, the mortality increases by 30%. When you treat patients with stroke, when you look at this U-shaped relation, you know that you cannot be absolutely accurate in achieving the blood pressure control. Blood pressure is going to be little higher or lower than the target. Always err on the higher side of the BP in the setting of acute ischemic stroke. Never try to err on the lower side of the BP, which is the reason why I put this slide to make you sensitive to this very important data as to what can be skewed when you try to achieve the blood pressure too low. So the question to ask is that if you are going to discontinue antihypertensives in an otherwise stable patient, or you are not going to start antihypertensives in acute ischemic patient, when will you start antihypertensives? Point is, In a patient who has got a target organ damage, for instance, as I mentioned, myocardial ischemia, a congestive heart failure, an aortic dissection, an acute renal failure, or if the blood pressure is too high, meaning BP more than 220 systolic, diastolic more than 120, we know these patients would risk a target organ damage straight away. If this is the case, then you can start the blood pressure medications immediately. But if the blood pressure is less than 220, 120, let us say it is 200, 120, leave it. If they do not have target organ damage, leave it. Wait for at least 1 or 3 or 5 days. What is this 1 or 3 or 5 days? That is the time we can achieve some neurological stability. That is, the patient has got a stroke. He is not further deteriorating. Once that neurological stability is achieved over 1 to 5 days, when you see them and you are convinced by clinically examining them that there is no further deterioration, at that point of time, you can start. Theoretically, oral antihypertensives can be started within 24 to 48 hours because most of the acute processes, such as worsening of the ischemic penumbra or an expansion of a hematoma and an acute hemorrhagic stroke, these things are rather uncommon beyond 24 hours. That's the reason why we try to choose one day. But in another patient who is actually deteriorating, you would actually wait for some more time before you start antihypertensives. Maintain BP, our approach is to maintain BP at intermediate levels until neurological stability. There are certain special neurological circumstances. For instance, as I mentioned, if a patient has got a progressively increasing cerebral pressure, intracranial pressure, or a progressive cerebral edema, ongoing cerebral ischemia because of occlusive cerebral disease, or there is a symptomatic vasospasm, or postoperative changes, have individualized management. For instance, if the ICP is going up, at this point of time, if you try to reduce the blood pressure too aggressively, patient will further worsen. So this situation should demand how much you will reduce the blood pressure. Usually after 1 week, patient have achieved neurological stability. At this point of time, you could use aggressive treatment for secondary prevention of recurrent ischemic stroke. In one more precaution we need to remember, this is a special situation. I always insist that either you do a CD angiogram or an MR angiogram or a carotid or a vertebral block. But the reason is because if you find stenosis, now this patient will have more reduction of blood pressure, more reduction of intracranial perfusion following stroke. And in such patients, be even more slower. Reduce the blood pressure over 7 to 10 days. Never be aggressive. If you are able to revascularize it, for instance, in a carotid stenosis today, we can revascularize after 48 hours itself. Once you have achieved revascularization, or you actually thrombolize them and the vessel completely opened up, or you do a mechanical thrombectomy, it opened up. If you have achieved revascularization, then you know that at this point of time, you can be aggressive. If a person got a carotid stenosis, be slow in reducing your blood pressure. So the target should be maintained. As to how much will you reduce? Is there a number? Is there some number? The answer is yes. You should not exceed 15% in the 24 hours data at any point of time. Now, case winner 3. A 53-year-old gentleman, he presents to the casualty of 1 hour duration. He has expressive aphasia, right facial palsy. He also has a right brachial weakness. He was a known hypertensive. As is usual with our patients today, he stopped all medications 1 month ago. When he came to the emergency, his BP was 190 upon 120, and CT scan shows some early signs of infarct over the left MCA territory. Here are the 3 questions. Should we use any antihypertensive now? If so, what? What should be the goal of such treatment? Now, the answer to this question is that yes, we must start antihypertensive. The reason is because this person is a candidate for thrombolytic therapy. If the blood pressure is elevated to a significant nature before we institute thrombolysis, this is a risk for hemorrhagic conversion of the infarction, and therefore we must reduce the blood pressure. Now here is my question 6. In a patient who is considered for stroke thrombolysis, what is the target blood pressure before you will start thrombolysis? You could choose choice A, B, C, or D. Let me pause for around 10 seconds or 15 seconds for anyone to post their answers before I give the answer away. No, the answer is it has to be maintained less than 185 or 110. There are people who want to be very aggressive and try to reduce the BP to 160, 90 or 170, 100. It's not a good idea at all. We do not know the lower limit. However, it is sufficient to know that if you go down much on the blood pressure, the chance of ischemic penumbra becoming worse is very high. So try to reduce the blood pressure to less than 185 or 110, nothing more. Do not achieve higher blood pressure. On the other hand, once you have thrombolyzed them with this target, after this, the target should be less than 180 upon 105 for at least 24 hours subsequently. The reason is because if you do not maintain that temperature again, if you do not maintain it subsequently down, then again there will be a hemorrhagic conversion of the infarct, which can easily happen. So we must be cautious about it. On the other hand, overtly reduction of blood pressure is also harmful. Now, what drug would you choose to decrease the blood pressure before thrombolysis? 4 choices: sublingual nifedipine, oral nifedipine, intravenous labetalol, intravenous sodium nitroprusside. Wait for the answers to be posted. Mr. Harish, were someone able to post the answers there?
Yes, I have got one answer only, sir. I think that was your 4th question.
Okay.
On acute
So
stroke
somebody
setting.
is able to answer also. Doesn't
Yeah.
anybody answers?
They
It's
will
fine.
have, yeah, because they have to mail it, so that it will take
Yeah, it's a
some time.
difficult
That is this
platform to
slight
get. That is
concern.
okay.
Yes.
All right. So I'll go to the answer to this without wasting much time. The answer is that among these choices, IV labetalol is best because sublingual nifedipine can produce precipitous fall of blood pressure. IV labetalol, quite easy to use. We use 10 mg IV bolus. We can repeat it 3 or 4 times. In a patient where you are not able to achieve beyond 4 times dosing, we now give an intravenous infusion of labetalol because the duration of action is quite short. We can always easily titrate it, and that's a drug of choice here. Do not prefer sodium nitroprusside because it has a venodilator effect and it can theoretically increase the intracranial pressure. So also with nitroglycerin, nitroprusside, they're all not good choices at all in this acute setting. Now, this is a patient who was treated as a corporate hospital for ischemic stroke. After a month, as a family physician, you see him and you have to decide about further management strategies, including hypertension management. This person is on aspirin, statin, and nebuvolol. His blood pressure is 140/80. Will you add another antihypertensive now? If so, what? Now, here are the choices: ACE inhibitor, calcium channel blocker, diuretic. Now, leave him alone. Wait for 10 seconds for the posting of the answers, if anybody is able to do it. Now, before I go to this answer, there's another question. Now, in this case, when there is a brother of the patient, he wants to know that should he be on antihypertensives to prevent stroke? So you check his BP 3 times, you see this BP is 140, 150, 90. Which antihypertensive you choose for him? The same choices apply to this patient also. So question 8, question 9 can be posted in the Gmail of Mr. Harish Murthy. Now here is my discussion. So what is the take on antihypertensive therapy in patients who have already got a stroke or TIA. Point number 1. You have to use antihypertensive for anybody whose blood pressure is at least 140 or 90. This recommendation is grade 1A recommendation. So the point I'm trying to make is that 140/80, the systolic is high. That patient definitely requires antihypertensive. Now, in a patient who has got an atherothrombotic or a lacunar stroke, or the etiology of the stroke is not known, that is cryptogenic stroke, if the BP is more than 120 or 70, you need to still give them antihypertensives, because these are all small vessel ischemic changes which are likely to progressive with persistent hypertension. This recommendation actually is a lower recommendation, grade 2C recommendation. In a patient who has got a cardioembolic stroke, where you do not have an atherosclerotic burden, a clear-cut embolism, if the BP is less than 130/80, don't give them antihypertensives. If at any person, if the BP is less than 120/70, don't start them on any antihypertensives. These are the clear recommendations for giving antihypertensive and their goals. So which drug is for what? This issue has not been resolved fully, but there are several guidelines available from the available data. Now, for the secondary prevention of stroke, as you saw in this case, when at 8 I gave you, ACE inhibitors alone are diuretics. They are the best data. For primary prevention, calcium channel blockers have the best primary data. Beta blockers, they do not have any stroke benefit. Therefore, question number 8, the answer is choose ACE inhibitor. Question number 9, this is primary prevention for stroke. Though you're treating hypertension, for him, the answer is calcium channel blocker. Now, case minute 6, a 55-year-old gentleman, previously known diabetic, treated elsewhere for acute ischemic stroke, left MCA infarct, has now improved. His power is grade 4/5. He comes to your clinic for further management. Following stroke, now your BP is elevated. In your office, 160/90. He is not on any antihypertensive. What is the target for this patient? I've given you 4 choices. Question number 10 can be posted in the email. Keep on asking questions to yourself. You will find more answers. Now, the answer is, we divide patients with stroke into 2 groups. The high-risk group, which ticks for any of the parameters which I mentioned: associated diabetes, heart failure, atherosclerotic cerebrovascular disease, chronic kidney disease, age more than 65, or a calculated 10-year risk more than 10%. If this high risk data is there, then for them the target is less than 130/80. If none of this is ticked, they are called as low risk, where you can have a target of 140/90. So with what therapy would you choose in this setting, in the patient which I gave you? Is it monotherapy or dual therapy? The recommendations are as follows. I mentioned the target is 130/80 in this patient because the patient has diabetes and hypertension. So you always look at the goal. If the blood pressure target is less than 20/10, for instance, if this BP was 140/90 or 150/90, monotherapy is sufficient. But if the BP goal achievable is more than 20/10, always use dual therapy. So this patient was started on perindoropil and amlodipine. He was reviewed after 2 weeks. The patient was showing steady improvement. He has no other complaints, but the blood pressure is 90/70. What will you do with the antihypertensive regimen? Will you leave it as such? Will you stop perindoropil or amlodipine? Or will you substitute cilnidipine or ramipril for the other agents? Pause for 10 seconds, then I will take you to the answer. Now remember, if a person, we don't want a target of 90/70 at all, but inadvertently, if the patient has reached such low value, but he is asymptomatic, better leave him like that. If he starts showing symptoms like a postural hypotension symptoms, then it is a good idea to go and do it. If there is another indication, do it. Otherwise, leave him like that. Now we'll shift quickly to spontaneous interstitial hemorrhage. Now, marked increase in blood pressure will invite expansion of the hemorrhage and potentially worsen the outcomes. On the other hand, you still need to have an MAP which is high enough to produce cerebral perfusion. Earlier data had shown that any systolic BP less than 130 will worsen ischemia, especially you can have a perihematomal ischemic zone, and therefore patient's neurological status could worsen, and it's a dilemma for us. Now, these are the present recommendations. If the systolic pressure is 150 to 220, then you can target blood pressure of 140 straight away. And you could do it how fast? Within the first hour of presentation, if the patient is clinically stable, do it. If the systolic BP is more than 220, the first target is to get it below 220. Get it. After that, gradually reduce the blood pressure over a few hours with a target systolic of 140 to 160, provided the patient is clinically stable. However, if the patient is unstable, anytime when you reduce the blood pressure, the patient starts deteriorating. Do not further reduce the blood pressure. In fact, to try to reduce the antihypertensive regimen, you can use the intravenous medications which you can just titrate it down so the blood pressure doesn't fall any further, so the patient will not deteriorate. Now, this was based on two important trials, the INTRACT-2 data and the attached data, which showed that lowering systolic blood pressure to 140 is probably safe. We can use many IV medications, labetalol, nicardipine, esmolol, enalapril, hydrazine, nitroprusside, nitroglycerin. Usually avoid nitroprusside, nitroglycerin. You can use any of the other agents. Fortunately, they are aware. It's not enalapril, but enalaprilet. I made a spelling error there. Aneurysmal subarachnoid hemorrhage, I mentioned that avoid vasodilators like nitroprusside and nitroglycerin, like I mentioned, for the spontaneous intracranial hemorrhage, because all of them can produce the increased cerebral blood volume and therefore the ICP can increase. Prefer only labetalol, nicardipine, and enalaprilet. Lowering blood pressure will reduce the risk of rebleeding in a patient whose aneurysm is still not clipped or coiled. But if you aggressively lower the blood pressure, the risk of infarction will be increased because there will be vasospasm. In the absence of ICP measurement, we can do an ICP in our hospital, but where we do not have the facilities, you can actually titrate the antihypertensive as follows. That is, if the blood pressure is not very elevated, do not give any antihypertensives. You can use cognitive status. In a patient who is alert, this means his cerebral perfusion is good. That's why he is alert. Now, if you try to reduce the blood pressure now for this patient, it will decrease the risk of re-rupture. Keep the systolic BP around 140. On the other hand, if the person is unconscious, this means the intracranial pressure is very high. To him, if you reduce the blood pressure, his consciousness will only further withhold the antihypertensives. I'll stop here and take questions. Thank you, Microlabs, once again. Thank you, Mr. Murugesan, for the opportunity. I'll wait for questions and stop sharing.
Yeah.
Thank you, Dr. Meenakshi Sundaram, for your nice presentation. You have brought out everything from the mechanism of blood pressure auto-regulation in the setting of acute stroke and how to manage with nice clinical vignettes. It is really an informative lecture for each and every one of us. Thank you, Dr. Meenakshi Sundaram, for your nice presentation.
Thank you very much, sir. We'll wait for the questions.
Yeah.
If you have questions, kindly let me know.
So there are some questions. Murugesan sir, there one or two questions are posted on our chat box.
Yeah, you can read the questions and he
Shall
can
I
answer.
read it out, sir?
Yeah.
Yeah. One question is, how do we treat a patient with isolated diastolic hypertension? That's the question, sir.
So this is a question actually Dr. Murugesan sir will take. Because as I mentioned to you, I do not do primary practice. So sir can teach us. Sir, please, sir.
There is no specific drug to treat isolated diastolic hypertension, sir. Any drug what we use for treating systolic hypertension can be used to treat the diastolic hypertension also. There is no specific drug.
Okay.
Thank you, sir. Thank you.
Thank you, doctor. There's one more question. What's your personal opinion about ARB and beta blocker combination?
All questions for Dr. Murugesan, sir.
Yes.
Let me just put in my points if possible. And one of the recent target trials, I thought it showed that the combination is not a good idea at all. Correct, sir? It produced unacceptable, drop in blood pressure, risking some renal dysfunction is what I remember reading about it. Murugesan sir could teach us about it.
Yeah. Actually, it is very much useful when there is hypertension and associated comorbid conditions like ischemic heart disease or previous CABG or previous angioplasty. In hypertension, if the patient shows features of sympathetic overactivity, the combination of ARB along with beta blocker is an ideal choice. Most of the Indian hypertensives have increased sympathetic overactivity. So the combination of angiotensin receptor blocker and a beta blocker.
Understood. It was ARB with beta blocker, is it?
Okay. Yeah, beta blocker.
Sure. Oh, okay, got it. Sure. Sure, sir. That's a good combination. As I mentioned in my presentation, beta blockers do not have a great benefit in further reducing the stroke risk in patients who are hypertensive. But it's a good idea to give beta blocker for the other indications mentioned. ARB is good enough. From the trial which came called the LIFE trial, and there are Candisatan trials, there are so other trials. The point is that when it comes to stroke, any blood pressure reduction would work. Actually, we don't have hardcore data to say that one class of antihypertensive is highly superior to others.
Yeah.
Some medications, yes. For example, the best available evidence is on two medications. One is Ramipril. That was based on the heart outcome prevention extension trial. That is a HOPE data, which actually was initially targeted towards myocardial infarction and hypertension, but later on it was extrapolated to stroke outcome data also. So what our stroke data showed was that Ramipril administration in patients who have got stroke significantly reduced the risk of secondary strokes. There was a good reduction of the relative risk, though not as much in the absolute risk. Good reduction was achieved in the relative risk. And what is interesting in that is that as an antihypertensive, Ramipril was quite weak. The blood pressure reduction that was achieved by Ramipril was not enormous. That data used even up to 20 milligrams of Ramipril did not achieve a good BP reduction. Despite this, there was a significant benefit in stroke reduction. So there was a good idea which got about the HOPE trial. The second stroke trial is a progress data. So that was actually using perindropil with or without additional indapamide. And the progress data also showed significant benefit. There two things were seen. Perindropil itself reduced it, but it was combined with indapamide. There was a significant reduction of blood pressure, which additionally contributed to the stroke reduction. So best data as of now is available on perindropil and Ramipril. Now there are other data which has been shown on other medications as well. The LIFE data on Losartan, the Candisatan data. On target telmisartan, yes, okay. So there are so many data which has come with respect to stroke, at least I could say.
Right. Thank you, sirs. One more question is there. It says use of metoprolol in ED. So that's
What
the
is
question.
ED, sir? Erectile dysfunction?
It must be, sir. I mean, that is what some Dr. Gopi Arkachar has posted that.
Use of?
Use of metoprolol in ED.
I don't think it has any indication for ED.
Right.
Metoprolol. Actually,
Will
all
not
beta
be
blockers are notorious to produce
worsening.
erectile dysfunction.
Absolutely. I probably, sir, it is metoprolol or beta blockers. Do they cause ED, or whether metoprolol is safer in such as that could be the question, sir. Which beta blocker would be safer to use or would not cause ED? I think that is how probably we need to take it, sir.
Sir, would metoprolol also equally produce ED, sir?
Yeah.
Murugesan, sir.
Yes, sir. Yes, sir.
And is there a safe beta blocker which will not produce ED?
Bisoprolol, they claim it will cause less ED. That's all. But no beta blocker is devoid of ED.
But sir, Murugesan sir, what has been your clinical experience, sir, of using these beta blockers in such situations?
Most of the patients are reluctant to give that history.
Okay.
So we cannot categorically say whether the beta blockers produce ED or not.
Fine, sir. Fine. Yeah, I think there are no more questions, sir. Mr. Shirish, would you want to?
Yeah, that's it.
Close.
First of all, thanks to Dr. Meenakshi Sundaram for giving us a wonderful deliberation, and I think it was quite detailed and quite informative. To also thank Dr. Murugesan for moderating and being a part of this session. And for all the people who logged in, thank you very much. You have been a wonderful audience, and look forward to getting you back for our next monthly webinar on beating hearts. Thank you, sir. Thanks, Dr. Meenakshi Sundaram and Dr. Murugesan.
Thank you, sir. Thank you.
Thanks for your
Thank you
time.
so
Thank you,
much,
Murugesan, sir. Thank you, Mr. Harish.
Thank you.
Thank you.
Thank you very
Thank you,
much.
Dr. Murugesan, Dr.
And wish all of you a very happy, prosperous Dasara festival.
Thank you, sir. Thank you.
Thank you.
Thank you.
Thank you, sir. Bye.
Thank you. Thank you, sir. Thanks for your time.